Sir, please start.
Yeah. Good evening, friends.
Mina, sir.
Welcome back to our session for the month of October. We welcome you all. At the outset, we'll just share one, not a good news, but for the all that our Pakmode sir has not been there today for his personal loss. So our prayers are with him. And then we welcome you, and I request Dr. Amul Pawar, our Joint National Convener and Secretary IIP Maharashtra, to guide
Yeah.
the session.
Thank you, Meena sir. Sir lost his beloved sister, and she was ill. She was critical since last 1 week, and so continuing with the academic after the uh, elections, and this was planned much before. And I thank Dr. Dayanand Nakate sir, Sagar Lad sir, then Dr. Jyoti and Dr. Anand Bhutada. I had all the pediatric intensivists for consenting and taking time out of their busy schedule. So we know all pediatric intensivists are there. So the case we can judge that it as the case might have a very critical course, and they have managed this case, I think, at New Era Hospital, which is a very unique hospital and pediatric super specialty hospital in Nagpur. Dr. Anand sir, Dr. Sanjay sir are both there as a directors, and I hope this will be a very fruitful discussion. And both the expert, Dr. Dayanand Nakate sir and Sagar Lad, they will be answering the this googlies and all these things by Dr. Jyoti and Dr. Anand Bhutada sir. I welcome all the today's delegates, all the executive board members, all office bearers of various district branches, and all the PG students as well. And wish you all happy learning. Thank you. Over to you, Meena sir.
Thank you, Amul. I invite our friend Dr. Sanjay Deshmukh, Convener Maha-IP, to grace the session.
Good evening. Firstly, after a hectic festival of Diwali and election, we are back to the academics. And Maha-IP is known for his academic to continue no matter the situation there. Maha-IP offers our deep condolences to our dear Dr. Sanjay Pakmane sir for his personal loss. We are with him in this time. Today we are continuing our Friday Ka Punch Shelock journey, and I'm very happy today. We have from my own New Era Madhanchal team, the young Dr. Jyoti Mahajan, which will be under guidance of Dr. Anand Bhutra. We will discuss in one interesting case. I doesn't know the details of this case also, and today we have two critical care experts, Dr. Nakate sir from Solapur and Dr. Sagar sir from Pune. So I hope Dr. Meena sir and his team will take this journey of happy learning forward. So welcome and happy learning.
Thank you, Dr. Sanjay Deshmukh, sir. Brief introduction. We have with us, starting from Dr. Jyoti Singh. Thank you, Dr. Jyoti Singh, madam, for being with us. She is the postgraduate student at New Era Hospital under the mentorship of Dr. Anand Bhutra, my own friend, a good student of my own. I am very proud of him, doing great. He's a director of pediatric critical care at New Era Hospital at Nagpur. Another good friend, Nakate sir. He is a pediatric intensivist and pediatrician from Solapur. And another good friend, Dr. Sagar Lad. He is a pediatric intensivist at Pune. So with this brief introduction, we start the session. Over to Dr. Anand Bhutra sir and Dr. Jyoti. Thank you.
Thank you, sir.
You can start, Dr. Jyoti, you can start sharing and start.
Okay, sir.
Yeah, make it full screen, Dr. Jyoti.
Yes, sir. A very good evening to all. So we have come here to discuss a mystery, and
Jyoti, it's still not full screen. You are not sharing your screen.
Actually, it's being shared from my side, sir, and the full screen is there.
Got it?
We can see your screen, Jyoti, but it's not full screen.
Ma'am, stop your sharing. Ma'am, stop your sharing. And
Okay.
while again sharing, you will get two windows. One is with small sharing and one is with full screen. Select the full screen.
Okay, ma'am, I'll try it again.
Yeah, please. While sharing, you will get two windows of your same presentation. Yes,
Yeah,
it is
it's good.
perfect, ma'am. Thank you. This is perfect.
But the screen is not moving from my side now.
Use the arrow keys. Use the arrow keys.
I'm still
Up
not.
and down. Up and down. First, click on the screen.
Yes,
First,
ma'am.
click on the screen and now use the arrow keys.
Yes, ma'am, I have clicked. Yeah, it's moving.
Yes, it is working, ma'am. It is
Yes.
working. Okay, thank you.
Shall I start, sir?
Yes.
Okay. So we have this patient. He's 10-month-old male child. He's second birth by order, born by third degree consanguineous marriage. He has presented with chief complaints of fever and cough. Fever was there on and off since 4 months. The fever was in between 100 to 102, which was every 5 to 6 hourly. Fever was not associated with chills. There was no diurnal variation, and it was responding to antipyretics, paracetamol. Cough was there also since last 4 months. Cough was not associated with sputum. There was no aggravating or relieving factors. There was rapid breathing at the time of fever, and cough disturbs sleep and feed. There was no poor feeding, no vomiting was there, no loose stool, no rashes over body, no ear discharge, no urinary complaints. There was no history of contact with tuberculosis patient or any chronic cough from any family side, no history of any traveling to outside, and not significant history of pet at home. But the child was not gaining weight since 4 months, and he was developmentally appropriate for age in all the four parameters.
What was the birth weight
2.5 kg,
and today's weight?
7.1 kg,
Health?
7.1 kg, sir.
7.1.
Yes.
So the weight was around 7 kg at around 6 months of age, and for last 4 months there was no weight
was
gain.
constant.
Now the child is 10 months old and its weight is 6.4, birth weight is 2.8. But last, since the illness has started, the child is not gaining weight.
Yes.
Yes, the
Is
weight
there
was
history of dyspnea?
Have you measured the other anthropometric parameter like length and the head circumference? Are they appropriate for the age?
so the other parameters were on the in between 3rd to 10th centile.
Okay.
So
Is there any
the
history of
height is,
dyspnea?
Sorry, sir.
Is there a history of dyspnea?
No dyspnea was there.
Whether the child is started with complementary feeds?
Yes, everything started after the child was started on complementary feeds, and the child was tachypneic and was always observed by the pediatrician at the time of fever. In between fever, this child was absolutely okay and playful. And for the fever that was there for last 4 months, it was not continuous. It used to be there for a week or so, and then with some treatment there used to be a break for few days, 3 to 5 days, and again it used to appear.
Whether it was a indoor treatment or whether it was
so she is going to elaborate the history
yes,
hereafter.
okay. Nay,
Yeah.
whether that treatment was this thing at OPD or admission?
Both OPD as well as IPD.
Okay.
Jyoti is going to
I
elaborate.
think
Yes.
let her finish the general examination and then we will discuss.
Okay.
Shall I proceed, sir?
Yes.
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 He was a full term by LSCS, appropriate for gestational age, 2.8 kg were the birth weight, and there was no NICU stay. Development wise, he was appropriate for age. For motor milestone, can sit without support, cruising was there, cognition and language like bisyllables were there, mama, dada, he waves bye bye, and socially, stranger anxiety was there. He was exclusively breastfed till 6 months, but as soon as the complementary feed were initiated, he had fever and cough. So, complementary feeds were not going on completely. Mainly, he was on the breastfeed. He was immunized as per the schedule for 6, 10, 10 and 14 weeks by national immunization schedule. So, coming to the history of presenting illness, as he was ill after 6 months, he was taking initially treatment on the OPD basis, like paracetamol with antibiotics, mucolytics, bronchodilators were going on, but there was no improvement. So, after taking treatment on OPD basis, he was firstly admitted on 8th of March for a day, then diagnosed as AFI with AGE. He was having loose stools at first episode, first time of illness, with moderate dehydration and anemia was there, for which he has received injectable zone and amikacin. In 1 day treatment, he was improved and then discharged on oral antibiotics. He was okay in between, but as fever was on and off there, so he was admitted on some another hospital in between 21st to 28th of March. This time he again had fever and cough. There was reduced oral intake. Clinically, he was stable with mild tachypnea and Krebs on auscultation. He was investigated thoroughly this time because he was having a history of approximately 1 month. CBC wise, he was having hemoglobin 8.8, WBC counts were higher, 19,600. Platelets were not, sorry, it was 6,06,000, and CRP was on the higher side. But LFT, KFT, urine routine, blood culture were normal. Considering the long history of fever and cough, he was investigated. Mantoux test was done, which was negative. Urine sonography was normal. As X-ray was showing some infiltrations, so HRCT was done, which was suggestive of pneumonia. And thus,
Do you have X-rays present?
Can we see the X-ray? Which pneumonia it is, right or left or?
No. First episode, not present illness. March 25 चा X-ray आहे का?
Yes, sir. I have
having X-ray. Yeah. So this is the X-ray that is there with the slide.
Can you zoom little? Next one.
Yeah, you can exit this one as a full screen, Jyoti,
yes,
and then you can see that one. Last slide. The last slide.
Yes, sir.
So that was showing basically bilateral fluffy sort of infiltrates, both lower zone.
Okay.
I can go back to full screen now.
Yes, sir.
So this X-ray is March 25.
Yes.
Okay.
So this time it was thoroughly investigated, and all the informations that we have collected from the discharge sheet. So from very good reputed unit, thoroughly investigated, treated, and the CT was also showing patchy, multiple pneumonatic patches, both sides, predominantly lower lobe, but also involving right middle lobe as well as the left upper lobe.
Okay.
Okay.
Next.
If you can do full screen, try to do full screen once again.
The full screen is visible now.
No.
Yeah.
It's,
No, it is not showing slideshow. It is just a screenshot.
I think that's okay. You can continue.
Okay.
but that will disclose what's happening in the next slide. So go back to the full screen.
Yes, sir. Is it visible now, sir?
No.
No, no, computer, you go to slideshow rather. On your PC, you go to slideshow.
So now is it visible at screen, full
Yes,
screen?
Yes.
yes.
Then again, child had fever with cough, but as he was orally accepting fare, vitally was stable. Parents not willing for admission, so taken treatment on OPD basis from 10th of April to 24th April. And he was receiving oral ZP and ofloxacin. Fever was on and off, but this time the fever was approximately 100 Fahrenheit. The parents were comfortable with it. This on repeat CBC, hemoglobin was same. WBC counts has increased from 15,000 to 22,600, and CRP has also increased. Rest of the investigations were normal.
And this was the X-ray that was done on OPD basis, right?
Yes, sir.
In the month of April.
But the child again had persistent high fever from 100 to 103 with cough with distress. So was again readmitted to third another hospital on 5th of May, which were continued till 20th of May. And this time recurrent pneumonia with non-resolving consolidation with sepsis was there. During the admission stay, he has received injectable piptas, amikacin, linezolid, meropenem, anti-flu as well, zone. And as this time the hemoglobin was fallen to 6, so he has received 1 unit of PRC transfusion. But as the child was not recovering, had persistent fever with cough and not accepting well, so was further referred to New Era Hospital.
So the main reason I guess was a difficult IV access. So this child, rather than having the persistent of symptoms, he was referred from a peripheral unit this time to us because there was hardly any IV access, and the child was receiving n number of medications every day.
So I think this child, are you going to do a systemic examination further, or going to go on lab test?
So what had happened with our hospital, rather than going for investigations, Jyoti first elaborate clinically what was there at admission.
Yeah.
At New Era, he had persistent fever, cough, weight was not gaining, weight was 7 kgs approximately since last 4 months, and obviously difficult IV access. On he was had fever, but he was otherwise stable. Only increased respiratory rate was there, approximately in between 50 to 60. And on further investigation, CBC, HB was same. HB was rise up to 12. WBC count was higher, and CRP has increased. Rest LFT, KFT, and rest of the investigations were normal.
Rather than going for investigation, just I would like to elaborate the clinical condition of the child. The child was thin with loss of fat, but active. And at the peak of fever, only the respiratory rate was high. And when the child was afebrile, the resting respiratory rate used to be somewhere around 26, 27, somewhere like that, without any retractions. And child was having pallor. There was no significant lymphadenopathy, no clubbing, no rashes, otherwise no sign of any other vitamin deficiency, no dysmorphism. Chest was having bilateral crepes, so that was there persistent. Occasional wheeze was there, but bilateral crepes predominantly on the lower sides. There was a soft systolic murmur on CVS, and CNS wise child was doing well, and there is no significant hepatosplenomegaly.
So I think this is in a nutshell is a 10-month-old child who starting getting fever from 6 months of age and has got a 4-time admitted. He is a failure to thrive. He has got the anemia, has got some gastroenteritis, On examination and X-ray wise, he has got a lung infiltrate. So probably he has got a chronic lung disease. Now this not a chronic, but it is a recurrent pneumonia, and probably this recurrent pneumonia may be either infective or non-infective. So first we need to rule out any chronic disease like congenital heart disease. That first we need to rule out by doing the echo, even though there is no murmur. Secondly, we need to rule out like a cystic fibrosis like picture, because he has got a recurrent respiratory infection. And thirdly, I will like to rule out for the immunodeficiency disorder, even though his count is on the higher side, like 22,000 were platelet and predominantly of neutrophilic. So maybe like neutrophilic functional defect like Chidia Higashi, or that part of immunodeficiency need to rule out when you consider this thing.
Looking at this, because the child has started with after usually 6 months, so immunological is more likely, because once the complementary phase for 4 to 5 months, the innate immunity is not there when the child is developing, then there is likely that it can start with infection. And all the time there is history of fever. So it has an infection component which is getting precipitated. Thirdly, as rightly said by Sagar, recurrent respiratory infections but initially started with loose motions. So possibility of cystic fibrosis cannot be ruled out. Thirdly, again, this immunodeficiencies. Can we have a clinical picture of that face of the child so that we can come to just like
some dysmorphic feature.
dysmorphic features, or some, just because Shireke Gashi and all that, they will have a classical picture human faces. So we can get the clue to that diagnosis.
Yeah,
Sorry,
right
sir,
now,
we do
unfortunately, we
not
don't have a pic of this child, but
Okay.
there was no dysmorphism.
Okay. Okay.
Very sharp looking child when this child was afebrile and very playful, active. Even at 10 months of age, there were at least 4 to 5 bisyllables with meaning.
Have you done any
Develop,
ABG?
developmentally, he was normal, if you
Yes,
think.
sir.
Yeah.
Any ABG done?
Yeah,
Right.
so we'll come to the investigation part. So what I
Okay.
can understand that we kept the differential diagnosis of recurrent pneumonia, where we thought of congenital heart disease, cystic fibrosis, primary immunodeficiency disorders, immunological issues can be there, or as there was a complementary diet was introduced, so we also thought of any allergic issues.
Allergic.
Yeah.
Yeah.
Pulmonary apostrophe, these things that can be because of the milk and all that.
Yeah.
Hmm.
Okay, so we can go back to investigations now, Jyoti.
Yes, sir. So these are serial CBC what we can collect from them. So in this we can see, sorry. So is the slide visible?
Yes,
Yes.
Can you go on the first slide of a lab investigation?
counts.
Counts.
Yes.
So WBC was in the rising phase. CRP was rising. HB was low in once on 15. HB was hemoglobin was approximately 8.88 nearby. Once it has dipped to 6, on which they have given PRC. Afterwards, it was around 11.2, and CRP was on a rising trend.
So the last ones are the investigations which came at the time of admission with us, right?
Yes, sir. So these are his X-rays. It was done on April and May. In between X-rays, they do not have additional.
Okay.
Further investigation wise, liver function test, kidney function test was normal. Procalcitonin was done, which was normal. Blood culture, urine culture were normal. Sonography was done, which was no abnormality was there. On 2D echo was done, which came out to be normal.
Okay.
Mantoux test, which was negative. MGIT CBNet for GL was negative. Bronchoscopy was done, which was on that. BAL was suggestive of Enterobacter species. And we have done PCR for CMV, EBV, which was also negative.
So while doing bronchoscopy, there was no anomaly, and there was no typical feature suggestive of alveolar proteinosis or any foreign
Yeah.
body. So that sort of things were not there. Uh, though there was a chronic sort of a inflammation in the airway, both upper as well as lower airways, and possibility of GR was kept on that basis.
Any
Possibility of H type
fungal
of
test,
PO fistula.
No, there
No.
was no evidence of TO fistula.
any
Okay.
fungal culture like aspergillosis
Especially,
were
Yeah,
done?
so we subjected
espe-
BAL for routine microscopy culture as well as PCR. So that PCR only Enterobacter species was detected, and sorry, on culture Enterobacter was there, and rest on the PCR there were no fungal uh, element was there.
especially H type of that gets missed even in bronchoscopy and all that. But it has to be special studies has to be done because it can present usually after starting the fees and all that. So initially it may not be symptomatic, but H type of PO fistula can be kept in mind as a background.
Yeah.
One of the
So
recommendations.
that you things to be very unusual to have H-type fistula presenting at this age with recurrent pneumonia. Usually, even with the feeds, they should be having recurrent aspirations, choking. That sort of history was not there, and still on bronchoscopy, we couldn't get any structural abnormality, any fistula like TO fistula. H-type fistula was not there, and even any anomalous rings or bronchomalacia that was not there.
No,
Any
usually
workup,
H type of fistula presents late, not as usually initially. That depends again on the defect, how much is the connectivity and all that. So that can be kept as one of the background these things kept in mind while we are investigating such cases.
any
Okay,
workup for cystic fibrosis was done?
Yes.
that's what ABG and sweat chloride whether it is
Yeah,
done.
So
ABG.
sweat chloride, I doubt if anyone is doing here.
In Pune, I think we do it
Yeah,
at
even
Okay,
KM.
yeah.
so Nagpur people who were doing the sweat chloride test earlier, it's not done nowadays, and we had sent genetics for that, and later on came out to be negative. The cystic
Okay.
fibrosis panel.
Okay.
Shall we move ahead with the case?
Yeah.
Yes. Yes.
Yeah, Jyoti.
Serum IG was done, which was also negative, considering immune allergy. ANA
IgA,
Priyanka Siyanka was negative.
IgG,
We checked.
IgA.
So, sir, that was a panel sent with
Okay.
immunoglobulins and IgA
Ah,
for cow milk protein allergen, and that was negative, not the
okay.
E. Serum Ig was normal, and serum IgA for specifically for cow milk protein allergen was
Was
negative.
Okay.
Ferritin was normal. Triglycerides were normal. LDH was within normal limit. Then we move
Yeah,
ahead with
we
the
can discuss here what all information that you need.
I think any more of a tracheobronchial tree needs to rule out any soft palatal cleft or any mucociliary like cartaginous syndrome. They can presented like recurrent respiratory infection.
Yes. So
So
primary ciliary dyskinesia
Yes.
was also one of the differential diagnosis here, and this not having child was not having any recurrent upper respiratory tract infection like typical sinusitis sort of a
sinusitis.
thing. It was presenting mainly with fever and cough. Uh, there was no situs inversus for sure, as we could see on the X-ray. The heart was on the left, liver was on the right. So initially we thought of this primary ciliary dyskinesia, and exome sequence was sent. considering all these possibilities that
Yeah.
we need to rule out cystic fibrosis, primary ciliary dyskinesias. So all those things were given elaborated to our geneticist. Yeah. In any other information, Sagar or Dayanand sir, if you want.
Hey, this again.
We sent urinary CMV PCR that was negative. That was less likely possibility for a term AGA child development to be
Yes,
normal.
yes,
Yeah.
But
yes.
we tried to rule out all atypical infections
And
here. Even an
LFT was
esophageal
normal.
swab was sent uh, for the common flu panels and everything that was negative.
And
Immunodeficiency.
TB was ruled out by gene expert in the BAL,
Yeah.
Yes,
isn't it?
BAL, initially gastric lavage, then BAL, and even before admitting here, the other center had done the gastric lavage. It was also negative, and there was no family history as such.
So I think it is more of a single organ involvement.
Respiratory
How are the
involvement.
other organs like the liver function test, kidney function test, any
Normal.
They were
acidosis on the blood
they were they
gas?
were
Normal
they were
every time.
okay. SGOT, SGPT almost 3 times. They were in the range of 20 to 30. Serum albumin was slightly on the lower side, somewhere around 3.5, 3.4 in that range. Raised INR was normal. Blood gas at room air was normal. There was no acidosis as such. CO2s were normal. PO2s were normal. pH was all the time around 7.37, 3.8. Couple of times it was done. So that was okay.
So
With
in
this,
spite of
this
this
much of this much of bad lungs and with this
yeah.
patient requiring 4 times admission, how PO2 and I thought will be normal for that particular
That
child, PCO2 and all that.
Yeah, that was
That
documented, sir.
that it is okay, but that will not fit into
And
this because
if you look
lungs
at
are
the
so bad.
CT, I think so.
Ah,
Jyoti has not put the CT here, so
no.
that was showing quite a bad lung. There were
Why?
multiple pneumonatic patches and early bronchiectatic changes. That was the CT that was done with our unit.
So it is early bronchiectasis,
Sarcoid, early
probably.
bronchitis, pulmonary fibros, these things, what we call it is.
So it is a chronic infective etiology, or more of, I feel, is more of a primary ciliary dyskinesia or recurrent pertussis. Pertussis is known to cause a bronchiectasis. So that was again a
Okay,
possibility.
that was this was a fully immunized child, and I'm sure at least couple of times azithromycin and one course of clarithromycin was given to this child. Uh, and having persistent high grade fever, that was there, Sagar. And he used to be afebrile for 3 to 5 days at the max, and then again fever used to be there 100 to 103 in that range.
Immunoglobulin levels were these things.
Yeah,
T
I
cell,
would
B
like to have
cell.
IgA and IgG T cell, B cells for that particular.
so that those workups were also sent, and so they were predominantly all the workup were normal. In primary immunodeficiency profile workup was sent. So of which immunoglobulin levels there was slightly raised IgE and IgG, but they were in the normal range only, higher side of normal.
So any
What about
whole
what?
exome sequencing done and it was normal.
No, so exome sequencing is still awaited. So before going for an
Okay.
exome sequencing, shall we move for one more test? If you want, we
Yeah.
can disclose to you. So Jyoti, can you put the next slide in?
Yes, sir.
So we did
NBT and
NBT and
DHA.
DHR. And why
It
we
is
thought of
neutrophil function
this?
defect.
Yeah. So we thought of this because we were trying to rule out, as our Sherlock Holmes were saying, that rule out the congenital hearts, cystic fibrosis, then immunological deficiencies and allergies. Typically, we thought because the kid was started on lentils, so we thought of lentil protein allergy as a cause for recurrent cough as well as a fever. So we stopped even the lentils in between, and couple of times we repeated bronchoscopy to see if there are any changes, but there was no improvement with that as well. And the child here improved transiently for fever for 5 to 6 days, and again started spiking when the child was inpatient with us. And the CT was showing early bronchiectatic changes along with multiple pneumonatic patches and few granulomatous lesions as well. So we thought that if it's not an infective cause, we should be looking at primary immunodeficiency as one of the possibility as a chronic granulomatous disease. So we did NBT and DHR, and these tests were positive. Can we see the report, Jyoti, here?
Yes, sir.
So this is the test report that was done, the screening test, and it came quite early to us. Uh, the screening test as compared to exome sequencing, which took almost, I guess, till the time of discharge, we didn't had exome sequencing with us. And when the child was discharged in relatively stable condition, and then we got the exome sequencing. So can we see the exome
Yes,
sequencing
sir.
here? Yeah.
DHR.
So it was chronic granulomatous disease, sir.
Yes.
Yeah.
Hmm.
So the report almost took a month to give us the diagnosis. But even by the time of discharge, we had fairly good idea that this is a chronic granulomatous disease.
So I think in this case, the first WBC count is on a higher side with neutrophilic predominance. And so that might be the one possibility we need to think of neutrophil defects. So
Yes.
in retrospective,
And
I think
you actually pointed out that, Sagar.
Yeah.
So the first one you thought that, and all the
I-
reports were showing neutrophilic leukocytosis.
persistent
So there were
leukocytosis was there.
recurrent,
More than 20,000 counts were persistently there, and it
yeah, yeah.
mainly the neutrophil count.
And the peak CRP was more than 350
Yeah,
as
yeah,
IPD.
yeah.
last month I had a same child who was admitted 4 times, the same case, and
Okay.
his whole exam sequence has come as the chronic granulomatous disease. Just we
Yeah.
received the report 4 days back.
Yeah. So our pediatric infectious disease expert Harsha Sonak is there, and the pediatric hemato-oncologist Dr. Atish Bakane. So we had involved them while managing this case apart from pediatric pulmonologist, and while going through group discussion in the hospital and looking at this picture, CT counts, and the first diagnosis was CGD only.
Yeah.
So this obviously took a lot of efforts by the previous hospitals, their reports, and we also went quite sequentially.
Yeah, it's a nice case.
So over to you for any questions on this. This child is now stable, active, and Jyoti can brief the present scenario of this child. So almost 3 months after diagnosis.
Sir, after he was started, he persistently had fever spike in spite of all the antibiotics and this, but otherwise he was active and playful in the interfebrile period. Weight was constant, oral intake was fair, but the parents had taken discharge against medical advice. Fever was still there, 10 to 12 hourly, and sometimes 36 hourly also the fever. The child is afebrile. He was on, at the time of discharge, on oral ferropenem and Septran. On when he came after on OPD basis with the report, then he was started on oral augmentin, itraconazole, and a Septran, and afterward there was no fever after starting on this prophylaxis. Parents have been explained about the need of bone marrow transplant, and funds arrangement are in process.
Any consanguinity of the history in this child?
Yes, sir. It is third
Second
degree.
degree causes. Third degree.
So it was a third degree consanguinity.
Yes.
Yes.
Okay. So after starting this therapy, now he's improving. Is he gaining the weight?
Yeah, he has started gaining weight. What's more important that he should go ahead with
Go for the
BMT
bone marrow BMT.
before the lungs are permanently damaged. So that's what we are explaining them. Already there is so much of damage to this child. He is going to be on lifelong antibiotics and antifungals, and still there can be intercurrent infections can be there, and lungs are not going to have the complete recovery. So that's why we have explained that go for the therapeutic procedure, that is BMT. Luckily, there is a sibling HLA typing has been done, and it's matching. And we have asked them to arrange funds and go ahead either here or to any other center they want.
Good. Any questions? Anything from the audience?
Yeah, I mean, I have couple of, if you're done from your side, I think we have couple of people from like Rajesh Kulkarni from Pune. Rajesh, your inputs, please.
Yeah, so very nice case. I think we need to, consider immunodeficiency in such a child. And a lot of times nowadays, whole exome sequencing gives us the answer. So I think we should use it appropriately. Uh, Second thing was I thought that it could be an IgA deficiency because it was only in the respiratory tract.
Yes,
So I
similar
thought it could be an
systematic.
IgA. Yeah,
Similar
that was what
systematic.
I
That's
was
why I was
thinking.
also asking for IGI levels.
Yeah, yeah.
Yes.
Yeah, we have with us Dr. From Amravati, our Tade sir. He is a geneticist and he's in area of interest of this chronic illnesses. So Tade sir, Naresh sir, your inputs.
Thank you, Sheikh. So nice case and well worked up. And as they said, so much of persistent infection, suspect respiratory problem. They have suspected cystic fibrosis, and our expert also initially suspected of immunodeficiency. Just want to know whether there is any history of delayed cord falling in this child.
They were not very sure. They were not
Okay.
very sure, but exactly what days. But it was definitely not more than 10 days as per them.
Yeah.
Yeah, and there was BCG scar was there.
Right. So persistently high TLC count in this case may one of the pointer toward maybe chronic granulomatous disease, and another possibility is leukocyte adhesion deficiency can be seen. And as I just want to suggest, you should also do before bone marrow transplant. You should also do the same sequencing Sanger validation in the elder brother or sister also.
Yes.
Because sometimes they may have variable presentation, and this may happen they may be affected, but they doesn't have the manifestation. It is always better before going for the bone marrow transplant, we should confirm that child is not affected.
Normal. Yes, sir.
Yeah.
Thank you, Naresh sir. We have Dr. Une sir from Pune. Your input, sir. Une sir is there.
Hello.
Yes, sir. Please.
Hello. Good evening, everyone. Actually, sir, I just joined a couple of minutes back, so I can't comment on this case.
No problem. So, anyone wants to add on their inputs?
Yeah,
In short,
I think so.
welcome.
Dr. Harsha Sonak is here. Says he is a pediatric ID expert, and she was a key person helping us diagnose this case. So, Harsha, if you are here, can we have your inputs?
Yes, I would. So, like I put in the message also. So, other clue was that the bowel culture was positive for Enterobacter. So, children with chronic granulomatous disease will have infection always with categories positive organisms. So, this was a categories positive organism, Enterobacter. So, it was one more clue towards CGD with leukocytosis, which was neutrophilic and a third degree consanguineous marriage. So, yes, sir. So,
Well, Anand, I have a couple of questions before we close.
Yes.
At the outset, one must say that it was very well worked up case, very well presented also, lot of persistence and perseverance. And you have come to diagnose it. That's important, number one. However, I have a couple of questions. Number one is that, uh, it's very uh, unique that you have only single organ involvement. That's number one. And number two, the type of organism that you grew. Of course, it is Enterobacter faecium, and it has always been said if you are growing the organism which is not expected from a particular site, think of something beyond, routine. So you rightly did. And if it is cystic fibrosis, the commonest organism is your this gram negative, right?
Pseudomonas.
Yeah.
Burgdorfia
So
shikajia.
Pseudomonas,
Pseudomonas,
gram negative.
Klebsiella, they
Yeah.
are more common.
So that's very. And the second thing is that you are lucky that this child has responded to amoxicillin. So I want to understand what is your explanation or thinking about this.
Okay. So this
Our
this
ID
this is
expert,
yeah, Harsha.
Harsha.
Sir,
We want to
so
learn
can you
actually.
repeat the question, please, sir?
See, generally, if you have a condition like cystic fibrosis and all,
Yes, sir.
it's the lung is the inhibitant for gram negative organism, essentially our pseudomonas. And
Okay,
you
sir.
got
Yes, sir.
Enterobacterium faecium, and you are lucky that the child responded to amoxicillin, the first line antimicrobial.
Yes, sir.
So,
Yes,
what
sir.
is your take on this?
So actually, sir, children with CGD will have infection with categories positive organisms. So your Mycobacterium tuberculosis, your Staphylococcus aureus, uh, even Pseudomonas, then Aspergillus, which is a fungus. All these are categories positive. So even Enterobacter. So this is Enterobacter. So which is gram negative organism. So it is categories positive, sir. Enterococcus will be gram positive. So this was a gram negative organism which is categories positive. So it was, it was in sync with CGD only, sir.
No, no, what sir
Have
is
you been
asking is
able to have you been able to
amoxicillin.
do the
So,
have you been able to do the multiplex PCR on this sample?
Yes.
uh,
And what was the result for that?
Sir, multiplex PCR was done, basic profile, and there were no significant growth for any other organism. It was on the culture that we grew Enterobacter.
So probably that panel may not be that intrococci. That was the reason. Otherwise, should have
Yes.
come positive.
Yes.
Yeah, we have with Dr. Jayan Upadhyay, sir. Sir, your inputs, please, and then we'll close.
Thank you, Minash. Thank you, Anand, and thank you all the panelists, Dr. Nakate, Dr. Lad, and all the personalities of IIT present over here. I was listening very quietly and very intently to all the discussions. Very nicely worked out case. Congratulations, Anand, and congratulations, Dr. Jyoti. Chronic granulomatous disease was on the cards right from the beginning when the investigations were put on, and everything, the counts were rising, the CRP was rising, the procalcitonin was negative. So that was coming up on the list as the follow-up was going on. I have a question. So nice diagnosis and nice management, everybody. My question is why bone marrow was not done earlier rather than later? We have done everything from ANA and all the other investigation to rule out autoimmune and all these things. When lung was the only organ involved and chronic granulomatous disease was on the list, why bone marrow was not done earlier? Anand, can you please answer? This is my query. I am not.
Bone
Even
marrow
bone marrow is
aspiration.
not done today. Even bone marrow is not done till today.
Yeah.
No, but bone marrow is not needed because his platelet is normal, his
Yes.
WBC is rising, hemoglobin is on lower side. You can do a bone marrow culture. That is the only indication for doing a bone marrow culture. Considering
Bone
it is
marrow.
the ALL or AML, that is another one thing is leukemia can present it with persistent fever, but getting a recurrent pneumonia, it is very unlikely that is leukemia causing such pneumonia with no other involvement.
Yes.
Yeah.
So
And usually,
Rightly said, Sagar. Sagar, you answered me.
leukemia will not be this will have an acute presentation because two series are affected. Sometimes they can happen third also platelets and all that. At that time, you will get again simultaneously hepatosplenomegaly, some bleeding tendencies. So that can be different presentation for leukemias. So per se, bone marrow will not give conclusive diagnosis, but definitely should have been think of.
Yeah. So we had
only
in
bone marrow
mind couple of
culture.
things that
Yeah.
HLH we should rule out. So we did
Yeah, HLH
investigations,
is also
markers for HLH, and then second thing was pulmonary hemosiderosis. So even with the bronchoscopy, BAL staining was done for PAS and everything. That was negative because this child had recurrent pneumonia with anemia requiring blood transfusion. So even that was kept as a diagnosis. And reason for doing cow milk protein allergy IgA test, that was that probably this child may be sensitive to that, and Hanner syndrome was one of the possibility initially when the child came to us. So but never that rightly said that it was not looking like a leukemic child.
Definitely.
Okay.
But usually over a period of time, months together, the patient will have
Probably,
they will have hepatosplenomegaly and all that. Other
Yes,
presentations will be coming up
that was
instead
not
of
there.
only one system
So
affected.
if you would have PO
Yeah.
and there is nothing there, like there is no lung involvement and
Then
anemic
we should
child,
have thought of
probably we would have thought of doing a bone
bone
marrow
marrow.
aspiration ruling out. But here in this case, as Sagar pointed out, taking a bone marrow aspirate and sending for culture, probably this is one of the indication for doing bone marrow, otherwise not.
okay. Thank you, Anna.
Yeah, thank you, sir.
I think maybe initial part we can do whole exome sequence early rather than I know it is easily available, maybe misuse also. But
Sagar, the geneticist asked us not to send before at least 30 days of transfusion. The child received
yeah, that's
transfusion
right.
on 15th.
That's right. That's right.
So we had to wait for a month before sending it. And
Yeah.
even if the child has received plasma or platelets, they don't allow us to send the exome sequencing.
Definitely.
Yeah.
I want to correct on this. This is not actually right because what we collect is the DNA, and DNA we get from the leukocyte. So if you are given the PCV transfusion, there is no need to wait for the 1 month.
Okay.
Yeah. So we can do the means I have
Genetic
done personally have done the many times genetic testing after receiving transfusion within 7 days also.
Okay.
And we can
So
get the positive.
next time, sir, I will ask this genetic team to talk to you, the lab people. Yeah.
Sir,
Don't
what
avoid
is that,
because
Dr.
waiting 1 month in this type of situation where you are suspecting
Yes,
the
because it
immunodeficiency
takes another 3 weeks
disorder,
to get the
maybe
result.
life and death situation.
Yes.
Dr. Taide, there are few tests that they run in 10 days and you get the test of whole exome.
Yeah,
How
rapid.
reliable is that? How reliable
Yeah.
is that?
They are also reliable. In India, we get minimum time of rapid whole genome or whole exome sequencing is 14 days. But in foreign, there are some ultra rapid tests which can give you result in within 3 or 4 days also. Minimum time of some result are 3 to 4 days only.
Okay.
Well, sounds good. I think this has been a very thought-provoking case. Well worked up, well presented by Dr. Jyoti. Congratulations.
Thank you, sir.
Well mentored by our friend Dr. Anand, and well dissected by our own Dr. Nakate sir and Dr. Sagar Lad. So we sincerely thank for being with us, accepting our invitation, being as presenter, expert, and the moderator for this case, so that we can run the show on time. And so also our friends, including our Naresh sir and Kulkarni sir and all our friends who are online. So we sincerely thank and we'll come back to again the fourth Friday next month with the new case. Thank you all. Thank you. Good night.
Thank you. Thank you.
Good night. Good night.
Thank you so much.
Good night.
Good night.
Good night.
अच्छा पल्लवी मैडम बंद करो. Yeah.
Thank you.
पल्लवी मैडम